My question is related to the antihypertensive of choice in diabetics with microalbuminuria, because the lecturer said that ACE and ARBs may not be particularly beneficial in microalbuminuria. So does that mean we go with maybe a calcium channel blocker like ephonidipine? Because our diuretics are out, thiazides except indapamide are generally to be avoided. So what should we choose as our first line agent?
You know, the RAS blockade reduces cardiovascular risk very significantly in these patients. So RAS blockade is very effective in preventing cardiovascular event. But the bottom line is lower blood pressure is what you need. So whatever it takes to lower the blood pressure beyond RAS blockade. RAS blockers are not very good antihypertensive agents. That's the problem. They work extremely well with other agents in combination, and it depends on the population. There's some people who are very salt sensitive. They'd respond to a diuretic. So combinations with RAS blockade and diuretics are good. Some people respond very well to calcium channel blockers. Now there are some, the dihydropyridine channel blockers increase microalbuminuria a little bit, but they lower blood pressure so well that at the end of the day, what do you want? Do you want to treat the test, which is microalbuminuria, or do you want to treat the patient and prevent cardiovascular events? And blood pressure lowering is what you need.
Can I go further with the question? RAS blockade, ACE and ARB. Would you choose ARB over ACE because
the data shows there's no difference in outcomes between the two, and the combination of the two is worse than either one alone.
Combination is out.
Combination is out, and there's really no difference in outcome. Now, there are theoretical differences if you believe in bradykinin and nitric oxide and all that kind of thing.
But you have more data.
Bottom line is 7-year data in on target shows no difference in outcome. Today, the question is irrelevant because the drugs are cheap. They cost the same. People, 15 to 20% of people get a cough with ACE inhibitor. You should not give it to them. So we use a lot of ARBs because they are well tolerated.
So you also mentioned that ACE inhibitors are not very good at controlling blood pressure. Now, coming back to on target, the difference between ramipril and telmisartan was only 1 millimeter of mercury. So they are as good as, ARBs, but somehow the concept.
I think you need to be a little careful there about the blood pressure lowering in the head-to-head because the patients were taking other medications as well, which are being adjusted.
But they were taking, if you look at two arms, the ACE versus ARB, both the arms were quite well matched in on target. And at the end, the blood pressure difference.
Yes, but they're taking other medications.
Yeah.
So in combination, it makes no difference and the outcomes are the same. So I think that you can use whatever is appropriate.
No, I asked because, I'll just say why I'm a bit in favor of ARBs than ACE is because if you take the renal studies, there was a renal study, there was IDNT. You don't have such a nice study with an ACE.
There's a reason. There's a reason, and that is ACE inhibitors became generic by the time they started doing these studies. So no company was willing to invest with an ACE inhibitor. So, whereas with losartan and renal, they were able to make money out of it. The bottom line, though, is that you're blocking the same system. There are people, the nephrology physiologists believe that you need to do more RAS blockade. But the problem is that the outcomes are not there.
Do you use cilnidipine a lot? Because the cilnidipine also has a lot of proteinuric effect. Antiproteinuric effect.
I'm interested in the outcomes.
So let me, in respect to the previous question, with the previous question is, when do you start ACE or ARBs? George presented data that if more than 300 milligrams of albumin, you must treat with either one of them. It doesn't matter which one to use. But in my practice and in our hospital, with data with microalbuminuria more than 30, I start them on ACE. I don't wait until 300, so I start them very early. I agree with you.
We started early. We don't do it for prevention of microalbuminuria. There's some people who at one time, and George showed the data today, showing it makes no difference in type 1 diabetes.
So do you use more than 30 or you wait until 300? I think 300 they're trained.
That's a little high.
Can I bring you back? Can I bring you back to Steno 2? Steno 2 was people with type 2 diabetes with microalbuminuria who were given ACE. Okay, there were many other interventions I accept, but the results are fascinating. So I agree with you. If there's microalbuminuria,
Steno 2 has 84 patients.
we can criticize Steno till cows come home, but
I want to ask a question. Will you change your therapy if the GFR is less than 60 or a GFR more than 60? Will it make any change in the outcome of the patients with diabetes with the evidence of nephropathy?
You know, 60 is a very arbitrary cutoff. Most of the patients that I'm seeing have GFRs below 60. And I think the problems start occurring when the GFR is around 45 and below.
Because they have a dip in GFR further the moment you give them ACE or ARB.
Yes, but I don't think, George showed very nicely today that it doesn't really matter because you get the drop and then it stabilizes. That's what you want. You want to change the slope of the decline in GFR. So I want to bring back the question that I asked George today, which is a real problem in practice. So we are doing the study he mentioned. We cannot find enough patients who are advancing chronic kidney disease. You're talking about people whose GFR is 30, no proteinuria. And there's a guy called IDEC in Australia who has published extensively on this topic of normoalbuminuric chronic kidney disease and diabetes. And his figures are somewhat similar to ours, that it's like 50%. Now, some of these people have had proteinuria before, microalbuminuria before. You block the RAS system, the microalbuminuria goes away. There's no proteinuria currently. And the criteria for doing the study is they have to be on RAS blockade at maximum doses and still have proteinuria, but most of the patients don't have it.
But would you also consider the possibility of a non-diabetic renal disease? Because in which case probably...
I asked him that question today and he had no answer.
Your threshold to do a biopsy would be very low.
We don't know what is going on, but the fact is that chronic kidney disease is progressing.
Yeah, in diabetics with a GFR less than 60, I guess 70-80% have hypertension. That's right.
Yes,
so it's
but
very hard to differentiate.
it's hard to know what is the cause of the problem.
Both can coexist together. You can have a diabetic...
What is true, and he didn't quite mention it, but he talked about mesangial expansion. The classic Kimmel-Steele-Wilson syndrome doesn't occur commonly in type 2 diabetes. You may get it a few type 1s.
It is a special situation where you combine the ACE and ARB. No, they're not integrated, but there is a situation where you can
never.
Persistent proteinuria, resistant hypertension.
The problem is that the outcome result is worse. You have more deaths, more kidney disease, and the really serious problem is hypokalemia.
Yeah, but in some situation where you have resistant hypertension, not responding persistent proteinuria, there is an indication.
Are you treating the proteinuria or are you treating the patient? I mean, I think you have to treat the patient to a good outcome. Now, I have a solution to this problem, but no one's taking me up on it. And that is the problem of hypokalemia, which is very real in these people because you also have some degree of tubular disease and tubular interstitial disease that contributes, the type 4 RTA. You now have very powerful drugs that lower potassium. That is the place for testing them, maybe in combination and along with the potassium lowering drug. Now they're very expensive. I can't afford to use them in my patients.
So I'm going to ask you this, that
We have a question from the audience.
Yeah, just one last point, that the serum potassium level, what is going to be your threshold to say, okay, hyperkalemia at this point, you got to withdraw or treat? Because I was talking to Bob Stanton.
It's a good
from
practical
Jocelyn
question.
Clinic. Just 1 minute, I'll complete. Bob Stanton from Jocelyn Clinic, I was talking to him, and he says that even with potassium of 6.4, they don't react. They say, we let them continue. And I said, that would be very bold. I would never risk it in my practice. But he says, if you have a chronic situation, nothing happens to them, and we just keep a watch on them. And they're very safe. Even with a 6.4, they don't react, they don't withdraw, they don't treat.
They don't withdraw.
So
the patient
what
goes
is the
to another
threshold at
doctor
which
who tells them, your doctor is trying to kill you.
Yeah. We have
America?
a question now from the audience.
So, what is the cutoff that you take as the upper limit where you would like
I get nervous above 6.
So, less than 6 is fine.
5.5 for me, 5.5 for me.
So let's have some audience
I'm nervous at
interaction
5.5
now.
and above.
Please.
I don't have any I say I get nervous. That doesn't mean that my patients are, I get nervous. That's all I can say. There's no data. I do not think that it's safe to keep people at 6.3 or 6.4 long term.
I get nervous at 5.5.
Okay.
And
He's a
if it's-
nervous,
So,
he's a nervous guy. He doesn't take
And
his
if it,
antibiotic.
and if,
So let's agree to disagree, I
if
think.
it's more than 6,
And-
I tend
yeah.
to stop.
We have
First
a
do no
question from
harm,
there.
first do no
This is a
harm.
live question.
Now to my dear experts, starting from this Children Diabetes Institute conference this year, this new concept of sex and gender medicine is coming in a big way. Now in India, we do not have that kind of data and experience. Now my question to you, considering the genetic factors, pathophysiology, and the importance of hormone in my women patients, should there be a different approach in treating my men and women patients?
I think that's a very good question.
Women
It's
with
asking about
diabetes.
Gender differentiation and the response of female sex versus the male sex so far as the therapy of hypertension is concerned. That's a question?
Yeah. Not only hypertension, it may be
Any
thyroid
disease.
problems
Yeah,
also.
any disease.
Yeah.
Yeah, I'll come to that. There are a lot of studies we have been done. If you look at any study, any data, you will see the number of female population is very small compared to the male population. Even in the animal studies, you will see that the female animals are not much studied compared to male animals. The reason being that the females have a lot of problems of their hormone changes, their menstrual cycles, and the getting out of the trials are very heavy, and the cost involved in involving the female patient in this trial is also very exorbitantly expensive. Looking at this, NIH has made it compulsory now that you have to have adequate number of female patients to be studied in every trial. That is made compulsory by NIH. Now the reason why male and female are different was obvious in the value study, which looked at the valsartan therapy in a female patient. And the female patients do not respond adequately to valsartan as much as the male patients respond. Now they went ahead and studied this aspect, and they come to a conclusion what is called sexosomes. Every cell of the body has an X and Y chromosome. In a female patient, there are two X chromosomes. So every cell has two sex chromosomes, and it is believed that the second X chromosome has an action on the effect of a drug therapy in a female patient. A lot of work has been done on that, and still it is preliminary. But one good news is that now the females are included in the same number as males, so far any trial is concerned. To answer the question, there is a gender difference, and there is a difference in which female reacts to a particular drug, whether it's antihypertensive, anti-diabetic, or any drug for that matter.
And as far as the treatment goes also, there are gender differences. Women are more prone to cardiac disease than men for the same duration of diabetes, etc. We have a very nice session on women and diabetes tomorrow, and some of these issues are going to be discussed in the panel discussion as well as in the talks, and it will be covered, and how the gender differs, I mean the treatment differs according to gender is going to be discussed tomorrow. So may we have the next question from the audience?
Wait until tomorrow, don't go away. No, it is female.
Good evening. One practical difficulty what I am facing. What is the maximum dose of insulin can be given to the patient without any complications? I have got
Maximum dose of
10
insulin.
patients who have more than 100 units of insulin consuming daily, basal bolus, plus optimum dose of OHA. Still their blood sugars are not coming under control.
I have used up to 1,500 insulin.
So, the maximum,
What is the limit?
Guillermo thinks that you should not give more than 0.5 unit per kilogram. I disagree with him. There are some patients who are very insulin resistant. It's not easy to identify them, but they respond extremely well to U500 insulin.
So,
Concentrated insulin.
so what I've said before is that this is a paper that is being reviewed right now. And we look at over 2,000 patients with type 2 treated with basal insulin alone. And they increase the dose. And you see a very nice reduction in fasting plasma glucose and hemoglobin A1C with doses for 0.1 to 0.2, 0.3, 0.4 units per kilo. And then you got very little. After 0.5 units per kilo, you don't see much reduction in fasting blood glucose or hemoglobin A1C, and the rate of hypoglycemia is high.
I agree.
So, but
I agree with you that for the average patient that's fine, but I think you need to identify the person who is
Insulin resistant.
very severely insulin resistant,
So-
and those people will respond to U500, sometimes 300-400 units,
how much is the maximum
three
use?
times
So,
a day.
how much-
I have
question
used
that
in,
he's
just a
asking is-
handful. I'm talking about a handful
Can
of
I,
patients.
can I ask you here,
5,000,
we don't have
6,000
U500, so just the three of you, your experience with U500. I've
It
never
is
used
excellent.
it. Now, how many patients do you have on U500?
I probably have about 100 patients.
100 on U500. Sundar, how many do you have?
I mean, it's interesting we talk about all this. I have about 15, 20 patients on because I'm in between.
We don't have U500. I've never
I
used
am
it.
in between Guillermo and this thing because if you think about it, why are we using insulin as the drug of last resort? And what does insulin do? These studies were done in the early, where did the 70-30 come from? How did that proportion come? Bob Henry, my boss, my mentor, did the studies with glucose clamp studies, and that comes to the 0.5 and the 1 unit. So he took, I believe it was 40, it's a paper in Diabetes Care 1993, 40 patients with type 2 diabetes. In those days, we only had sulfonylurea and insulin. So he brought them in hospital. He did clamps on them before, after. He started controlling it. I won't go into the details, but basically he used insulin. What he found was, NPH and regular, once you're giving up to 0.5 units per kg body weight, you've got the liver maximally, as best as you can suppress it. After that, the liver has to keep going, otherwise, you don't get glucose through the night. Then, going from 0.5 to 1 unit per kg body weight in these days, you have to push that glucose into muscle, because now the liver, you can't do anything more. You are going into the periphery, and now, as you're going, and those studies have been done, up to 0.5, you've got the liver about 75-80% suppressed. You cannot, using tracer studies. After that, you double, triple the dose. Depending on the peripheral insulin resistance, you are not. You are treating a number, the patient is getting fatter and fatter. He showed that very well. Somebody can look at that thing. So it is the law of diminishing returns. You go up, up, up. And then insulin has got many pleiotropic effects. In fact, when I talk to the students, I say insulin is a schizophrenic hormone. Why? Because insulin in the periphery causes vasodilation. Insulin in the kidney causes sodium retention. So the net result of insulin on blood pressure is this. But more interesting than that is insulin's effect on body weight. Okay? We all think insulin is anabolic. There are, correct me if I'm wrong, there are two hormones which regulate long-term body weight. Leptin, everybody knows. Nobody talks about insulin. Insulin is the second most important hormone which acts on the brain. The problem is insulin in the periphery is anabolic, lipogenic, antilipolytic. Insulin in the central nervous system is catabolic. You give insulin inhaled, intranasal
They've tried for
insulin.
obesity,
Those studies have been done. It goes straight up to the from plate of the thing and goes in and suppresses body, reduces body weight without causing any hypoglycemia. So the net result is in an individual person how resistant they are. And
And we have used, U500 has a different pharmacokinetic profile. So you use it 3 times a day. You don't need long-acting insulin. And we use GLP-1 in combination with that, on top of it. That is I'm not talking about your average patient, okay? Not Guillermo's patient. I'm talking about the ones who've given up on Guillermo, they come down south to see me.
So are there any patients, we can say that are just not treatable? I mean, do you go to a level where you have given, whatever you say,
He
0.5,
has 100
0.61 units?
I have done this. I
That-
can
do
tell
you
you
say that no,
these are,
because your
these
diabetes
are
just
people who
cannot
have
be
gone
treated?
to everybody else. They're on 200 units. Now, a lot of the time when I'm referred, I doubt whether the patient is really taking their insulin. Okay?
Because if after a certain limit the patient is not going to be benefited, is it out of desperation of not having anything else that we are increasing the doses and doing more harm? Should we tell the patient that because your diabetes cannot get controlled?
That's not true. I don't think.
Let me make a point about this very high insulin dose with U500. There are 3 papers, 2 papers and 1 that was presented at the Endocrine Society meetings of patients who had been taking U500 and are admitted to the hospital. They have very high blood glucose with an average insulin dose per day of about 500 units per day. They are admitted to the hospital. And the question is, do you really need 500 units? So the current recommendation is to reduce the dose by 50 to 75%. Stop you 500, and you say 500 units, so you give them 150. And they do not require more than that. Why? Because in the hospital, people don't eat or don't overeat. Let's put it in this way. So I think that a lot has to do with like Louisiana, New Orleans. You know, we have been there in all these restaurants.
I don't dispute that. The problem is, I'm getting back to what you say. You have patients, they've tried everything else, and the patient is sent to you as the last resort. What do you do? And some of these people we have admitted to hospital and then keep bumping the dose, and you can see it. There comes a time when suddenly they start, when you're getting to like 80 to 100 3 times a day, the blood sugar starts coming down. What else is it? Are you going to say, all right, I'm not going to do this because Dr. Umpira is in, you go to Atlanta and eat their food there?
No, there's an easy solution for that. See, insulin sufficient type 2 diabetic can never be controlled. It's not possible. If you can't control, get bariatric done. And see, when I was training, I worked with Edwin Gale, and he used to call this as black hole of diabetes. Because at that time we only had sulfonylurea, metformin, regular insulin, and NPH. And these obese people used to come, no matter how much insulin you give, you couldn't control. So he used to say there's a black hole of diabetes, can't do much. But now we have GLP-1, now we have SGLT2, and if GLP-1 and SGLT2 doesn't work, bariatric. I mean, I can never accept that a type 2 diabetic who's insulin sufficient cannot be treated.
But there are other types also
But
sometimes.
getting to your point, when you reach this point, I have patients up to 500 units. It's an anecdote, but this woman was there. She was on 150 units 3 times a day, 450 units. You can, we do the U500 and then we reduce it, okay? A1C is 10.5, 11. And it defies belief. And she swore she took it. Her husband came, yes, she would show the spots. So what we did, one day we told her come a little early to the clinic. So she comes at 8 o'clock. Blood sugar was 384. We gave 15 units of aspart. Right? And believe it or not, within 2.5 hours, we had to, not a code blue, we were scared. Her glucose plummeted down. She just never took it. She swore she took it. And then the husband brought back, she threatened him, you don't dare tell them that. Thousands of dollars of worth of insulin. So she refilled the prescription. So if you look at the refill, it's there. So that is the one. The second thing which we do is what Guillermo said. When they come into hospital, it melts away that insulin requirements. And when we've done the studies 20 years ago. We bring them we do the very low calorie diet. Within 2 days, person on 150 units of insulin needs no insulin and the sugars have come down because we control the diet. And last but not the least, I think he referred it, when I have this patient.
There are some real patients, no, who just do
So
that.
the very low calorie diet is a great treatment. What we need for the whole United States is to give people only 600 to 800 calories a day. We will solve the problem.
You will never
of
succeed.
diabetes.
You will never succeed.
Let me ask you one
Let me say one other thing. All right, since we are debating this issue.
No, I have a question. Hold on. Let me ask you a question.
You look at the sales of U500 insulin on market scan. It has skyrocketed in the last 10 years. Now, why is that?
Lily.
No, I think it's availability, and the availability now in a pen, and the fact that there are many people who they've not been controlled before, now they're controlled, taking 500 units of insulin a day, and
Because it's available.
what are you going to do?
Agreed.
I have a patient I know very well. Her A1C is 6.5. She takes 3 shots of U500 and GLP-1. What am I going to tell her? I'm going to take her U500 away. It's just somewhere like 500-600 units, and she's very well controlled. She's not gaining weight. She's happy. I'm happy. What do I do?
I have a question. Sleep. There was a recent paper in Diabetes Care that says that look at the prescriptions of anti-diabetic agents, oral agents, and insulin during the past 20 years. And from 90 to 2015. And in the year 2000, about 60% first agent was metformin. Right now, it's about 80%. So perfect. Everybody's following the guidelines. And when you add a second agent, sulfonylureas is still in the United States 44%. 44%. And insulin was third, and then the others was less than 12% for DPP-4 and SGLT2 was nothing at that time. GLP-1 is 3, 5, 7%. Yeah.
That paper you're quoting is 4%.
So, metformin, sulfonylureas. What would be the percentage of people in India treated with sulfonylureas?
80, more than 80%.
80.
Plus, close to 90.
More than 80%.
I don't think
80 plus?
80%.
I don't think JJ that will be the figure.
80 plus?
I think there is some study which I am not off the hand able to recall, but it is anything around 65 to 70%.
That is more like it, yes.
Got a question?
65 to
Yeah,
70%.
question.
So, what is the criteria of sliding scale insulin to be used in a critically ill ICU patient whose blood sugar is hovering around 300 to 400 milligram per deciliter for the last 3 days?
You have sitting here Dr. Perez, who says there is no such thing as sliding scale.
There is none.
Bullet is coming, duck down.
And in a critically ill ICU patient, what is the exact choice of insulin? Is it the long acting along with the short acting, or the Mixtard, or the Degludec? What it is exactly? Please throw some light on this.
Once you say critically ill patient, it has to be on infusion. Once the patient starts taking orally, you convert them to basal bolus. There is no.
One more part.
In the hospital sliding scale, let me tell you something that I will never say in the United States, but I'm going to say it here because it's new data and people will throw rocks to me. If the patient have a blood glucose less than 180, so the sliding scales work well. If your glucose is above 180, sliding scales is not good to control blood glucose as an average, that's right. So if you have a patient with diabetes, come to the hospital, glucose 160, 180, a sliding scale is going to work. But if you have a patient that is infected, glucose above 180, 200, the sliding scales alone will never do the trick. So why people have used sliding scale for so long? Because the surgeon, the average 63% of surgical patients have a glucose less than 180, 200. In those patients, sliding scales work fairly well. The problem is that most people are not admitted with glucose of 180, are admitted with 200 and 300, and using sliding scale in those patients is not good enough. But it works for some patients. The other thing is that oral agents work in the hospital. If the blood glucose less than 200, they work. In the ICU, same thing. I mean, the best thing.
That's because if the blood sugar is not very high, you're not giving too much, the patient doesn't get hypo.
Yeah.
See, I think if the general consensus now is that if the blood sugar is less than 180 in the intensive care setting, you are actually not doing really, great dosing, and very small doses, so 3 or 4 shots can usually cover. So that kind of intensive monitoring is not required. But somebody is critically ill means is kind of not able to take orally, is on IV infusion or the
patient with sepsis with a blood sugar of 300.
Have to be on infusion.
IV insulin.
They need to be on infusion. The target will have to be less than 180, of course.
I think Guillermo is a study of sitagliptin and insulin and versus basal bolus.
So that one I want to
So they are.
I mean, he said that works equally well.
Now, that study, little bit difficult to swallow.
Okay.
I mean, what was your baseline? How high were the sugars? Because, see, intuitively, it's very difficult to accept that sitagliptin plus a basal.
They didn't need anything and he gave them nothing.
No, so let me ask. I got the horse here now, you see. So, sitagliptin and basal working as good as basal bolus. Would you want to share? I mean, this is your normal practice or?
So again, DPP-4, we have 860 patients in 4 trials. There is one paper that is coming in diabetes care, 280 patients, surgical patients. And it works very well if the blood glucose less than 200, or 180, 200. If it's above 200, don't use sitagliptin, don't use metformin, don't use no oral agents, don't use sliding scales alone. Below that, you can treat them with whatever you want. So the average sliding scale dose in the hospital is about 8 to 12 units a day. So it's minimal. So you just give 2 units here, 4 units there, 2 units there. So that's more or less what the DPP-4 does. I still believe that the best way to manage people in the hospital is with 1 dose of basal. And then you do correction doses.
Okay, I thank the panelists. We simply have to close this session. Thank you all very much for being here. And we all meet tomorrow.